We at the Consumer Voice have had the great fortune of working for the past 3 years with Kelly and AARP Foundation litigation on a campaign, a consumer education campaign to share information, educate consumers about the dangers of antipsychotic drug use, and also about what good care looks like for people with dementia. And it's something that's been near and dear to our hearts at the Consumer Voice. It's been an issue that we've been advocating on. But, as you know, residents have the right to be free from the use of chemical restraints, which is what happens too often when antipsychotic drugs are prescribed for people with dementia. And you're going to hear more about that from both Kelly and Jonathan. But what I wanted to really do is talk about the resources that are available through the campaign, because they're there for you to be able to download, to be able to use, not only for education in your states, but also in advocacy and working with residents and families, and in training your staff, your volunteers, and also, I think you can work with members of the community and also with resident and family councils, and even sharing information with staff to raise awareness about these issues, to really kind of have them focus that there are better solutions than drugging people, and that's really what we want people to know. We started the work on the campaign because not enough was happening to change the culture of care in facilities. That for too long, it's just been systematically okay to drug people, both without their consent and for conditions that the drugs are not intended to provide any relief or any relief from symptoms or anything like that, and that's been wrong, and people have really been harmed by that, and even died as a result of it. And so we wanted to really raise awareness, because we really believe that the more educated a consumer is, the more educated not just residents but their families are about these issues, they can demand better. And we actually have heard from families that have demanded better for their loved ones, and actually made a difference for them. And then residents themselves, who have actually, individuals themselves who were inappropriately being drugged, and who made a difference for themselves because they knew what their rights were, and that they knew that there were better options out there. So as part of the work that we were doing through the campaign, we've developed a number of resources. These are all available on the Consumer Voice website, but we've got a whole host of resources available to you. We have training materials, we've developed PowerPoints, so we have video clips that you can use as part of training programs. We have a host of webinars that you can refer people to watch that include Kelly and Jonathan and some other folks. We've got podcast recordings that we've been working on so that you can, listen while you walk or drive or you're washing your dishes. That's when I listen to podcasts. And resources that you can download and hand out. We've got not just these cards that are being passed around to you, but we've got a range of fact sheets and information that were all developed based on not just what your rights are, but also trying to respond to some of the questions that we were getting from family members, like one we've called difficult is not a diagnosis. That's what we've called the document, because too often, we were hearing from family members and from ombudsmen that facilities will say to, a family, your mom's so difficult, she's a problem, she's got problem behaviors, you're gonna have to take her out. You either let us drug her or we're gonna discharge her. That's been a common occurrence, and so we wanted to kind of address some of those issues. We've got a pretty comprehensive webpage that has all of these information and resources. Articles and studies are included there if you want some of the background information. That's available for it as well. These are just some examples of some of the different materials that are out there that you can take a look at, that you can download. But we really tried to make them usable and accessible. There's a companion webpage, we have a main webpage as part of the work that we've done, but there's a companion webpage there too that goes through some of the good care strategies that can be used to help alleviate distress and to comfort people and to help provide better care and get at what is the root of the problem that we're talking about here, so that we're not just addressing the campaign or the issues related to the behaviors that are being shown. So we did a lot with the campaign. It's been a lot of fun to work on. Just because the technical campaign's over, we're not done on this issue. We're going to continue to work with Kelly and Jonathan and others. It's because it continues to be a main priority with us. But there have been a lot of great partners that we've worked with across the time of the project, including ombudsman and advocates. There's been a lot of training that's been done across the country, a lot of raising awareness, not just with families and ombudsman, but like I've talked to Medicaid fraud control investigators earlier this year about it. There's a lot of people that protection and advocacy staff, adult protective services staff, because there are a lot of intersections, right, in the work that you're doing. And so again, we wanted you to know that there are a lot of resources available. We've reached, just through the consumer voices channels, that's not including like the partner extensive channels, more than 300,000 people have been reached with the work that we've been doing as part of the campaign. So we've been really working on that. And as, the one other thing I wanted to share is, as we've been talking about this work, and I'm not going to go through, in specific detail on some of these slides, but as you're doing the advocacy, not only, should you be looking at information and resources that you can be sharing with other people, but one of the things I wanted to share with you today as well is as you're doing the advocacy, one of the questions we had been getting is like, as ombudsman, how do we know, or what do we do, about this issue, or how do we know that there might be a problem in the facilities that we're working with? And this is something that's going to be included in some of the training materials that have been posted for you all. So I'm just going to kind of quickly go through these, and you can hear more about it if you download or listen to those. But we really want you to focus on, before you go in, like kind of listen to what's been happening, but use your data, right? Because I think the data can tell you a lot about what's happening in a particular facility, not just your ombudsman data, where you could be looking at where are some problem areas in the facilities that you're working with. Are there problem areas in chemical restraints, for example, which, you're not often citing that because maybe you don't know, but look at your facilities where there are issues in your ombudsman data, where there are care issues or staffing issues or discharge issues, because the likelihood of there being more antipsychotic use in those facilities is likely to be happening. So, you could kind of, be asking questions about what's going on. Are they actually providing proper care to manage the distress that residents may be experiencing, or are they just trying to discharge them? Or, if they're short staffing, they're not really able or equipped to provide the best care possible. So, they're more likely to be trying to drug people in those facilities. So there are things you can be watching for, like for red flags. The other data point that I wanted to share with you is on Nursing Home Compare, which many of you are familiar with, but on every Nursing Home Compare individual facility webpage, in the quality measures section, so if you go in and you just kind of search for a facility, so if you're going to visit a nursing home, right, before you go, just pull up their profile on Nursing Home Compare and take a look, what's going on in that facility. So you pull it up, and I just picked, a random one in my state, and just put in the zip code, and the information will come up. But when you go to the quality measures section, there's short stay quality measures and there's long stay quality measures, right? The long stay quality measures, you're not likely to see a whole lot, or the short stay quality measures, you're not likely to see a lot of antipsychotic use, because most of those people are preparing to go home. They're there for rehab. They're, not really they're staying. They're generally more functional. They're kind of on their way. They're temporarily. But look at the long stay quality measures and what's going on there. And one of the keys there is the percentage of residents that received antipsychotic medication. And you can look at what the percentage is in that facility, and you can see how it compares to the national average and how it compares to the other state average. And what this can do is help you ask questions about what is going on in that facility. So if those numbers are higher than the state or national average, you can go to the nursing home and not only pay attention to are there residents slumped over, or are you hearing residents say that that they're groggy, or are you seeing more complaints about falls or pressure ulcers, or people not getting the care that they need? But it can also be an opportunity for you to ask questions like, how are you managing the distress that people are experiencing in the facility? Like, you can watch for that, right? Like, you could see how that's happening. Or in one of the sessions yesterday, the facility actually called the ombudsman and said, like, this resident is is causing all kind of chaos in our facility, so you, ombudsman, come do something about it. Well, if you get a call like that, like, first of all, why isn't the facility doing better assessment care? But, go and look, like, what's happening in that nursing home before you go in to even investigate that complaint. And then you can be asking questions. Well, have you done, like, you could talk about assessments and care planning, and have you done those things? But if you see that their numbers are higher or lower, it can cause you to ask questions about what is going on. How are you managing the behaviors better? And Kelly and Jonathan can talk a little bit more about, like, what that actually looks for. But I mean, definitely in terms of problem facilities, they're the lower starred facilities, they're the lower staffed facilities, they're the ones where you're seeing a lot of behavioral health issues. More likely you are going to find that those facilities are where the antipsychotic use is an actual problem, and that you may need to pay a little bit more attention, share some resources, make referrals to your licensing agency, make referrals to, I'll go back. These will be available to you, the slides will be available to you though. But make referrals to your licensing agency, make referrals to your Medicaid fraud control units. They're all really interested in all of that information. So I want to leave the time for Kelly and Jonathan. So these slides are just talking about different advocacy strategies that you can use. The slides are going to be available to you with the materials from the conference. But essentially it's just talking about some of, like, the questions you can be asking, some of the partners that you can be looking at in terms of who else might be interested in looking at some of these issues with you, so that it's not just you as ombudsman that are looking at them. There are a lot of people that are really interested. So with that, I'm going to turn it over to Kelly, but I'll leave the slide with our contact information up so that you can talk to us after, or contact us after the conference is over.
Thank you. So Lori, Jonathan, and I are sort of like, this is our road show. We kind of have done, and we talk about, this is one of our jointly held favorite topics. But I got into this because I had a number of plaintiffs come to me, like families, come to me over the years with horror stories about their loved ones being drugged without their consent in nursing facilities. And so these were people who were, I'm the power of attorney for so-and-so, my mom, and I turn up to the nursing facility. My mom is suddenly a different person, totally different, and I'm the power of attorney. So who prescribed these drugs, and with whose permission, is the question that the daughter raised. And it turns out that this doctor, and this cracks me up every time, but the doctor's name was Dr. Profit, and he testified that he basically gave every single person that he worked with across, he had 200 residents at any given time in 4 nursing facilities, and every one of them he prescribed psychotropic drugs to, and not one of them had he gotten informed consent from them. And so we were like, okay, well, there's our class action right around Dr. Profit. Everybody that Dr. Profit touched is now a member of our class. And because he told us nobody had informed consent. So we brought this lawsuit in California against a single facility where at the time he had about 100 residents. All were drugged up. And our client's mom had been only in that facility for about, I want to say 21 days. And every time she went a lot. And every time she went, her mom was sicker and sicker and sicker. And then on she kept saying, like, what are you giving her? So she cracks open, on the second week, she cracks open the file, her medical record, and sees that her mom is suddenly, for the first time ever, on 11 different medications. She went in there with no medication. She had the very minor dementia symptoms, but not even a full diagnosis of dementia. And so they were giving her all these drugs. But the doctor has never come in. The nurses, or every time she was in for rehab, she had just had a hip replacement. And so she's trying to like wiggle around in her wheelchair, and the nurses are like, this is a pain in our ass. Like, this is really not helpful for us. We just need somebody to give her something to stop her moving, because she's going to really hurt herself. And so they call the doctor faxes in an order. The next day, they're like, well, that didn't work. We need another one. Faxes in another order. This keeps going on until she's suddenly on 11 different medications, and she's just completely debilitated. She just cannot move, can't talk. She's slumped over. They've already had her tied to the wheelchair. So why did they need to like chemically restrain her when she's already physically restrained? But that's what happened. And so within 3 weeks, the daughter said, I've got to get her out of here. So she moves her to the hospital to try to detox her. It doesn't work, and then she dies a week later. So she came to us and we filed a lawsuit against the facility and the doctor. And we really it was just so overt what was happening, but it tied it together so nicely, because in California, there is a requirement that you get informed consent in the nursing home statute. And so you shouldn't, like, that should be normal, right? None of us, I'm not gonna go get my teeth worked on, someone's gonna like break my arm and refix it. Like, we have informed consent rules for a reason. We shouldn't have to tell everybody, like, don't do any surgery on me or don't prescribe medication to me without my permission. But in this facility, they had a specific policy, and this is not, I thought at the time, I thought this was unusual, but I've now since learned this is not that unusual. This facility had a policy that by signing yourself into the facility, you've consented to whatever treatment we're going to do in this. That means anything we choose to do. So informed consent is a documentable thing for you to look for. To me, this is like the red flag. This is the big thing that you should be able to go in and find the form that says who signed for this, what's the authority. If it was only a phone call authority, sometimes they'll just write daughter approved by phone. That's one of these things that I think is a really big red flag for you to look for. Who authorized it? When did they authorize? Did they authorize everything? Anytime you change the meds, it goes up, you should get informed consent, because it has a different repercussion for a person every time there's a change in the medication. If you stop the meds, that also requires informed consent, because an abrupt stop of some of these drugs is very dangerous as well. Then you have to be tapered off and watched. But the other thing that we realized in this case, and in many others that we did that followed, many of which we had Jonathan as our expert, we realized that once these drugs are in the system, nobody is monitoring for side effects. Like, these are serious mind-altering drugs, particularly when given to people with dementia, and I'll walk through a little bit more about that. But these are mind-altering drugs, and they have for some people, immediate detrimental consequences. Sometimes it takes a little longer, but some people immediately have Parkinsonian symptoms, shaking and different things like that they can't undo. Like, this is stuff that happens that taking them off even doesn't make the neurological changes reverse. So they are things that can't, for some people, it depends on, your combination of complexities, your medical complexities, your age, your other diagnoses, what other drugs you're on. There are side effects that you should absolutely predict with these drugs, and the failure to monitor for side effects is almost as bad as the initial diagnosis or the initial administration of the drugs, because that's where the people start, like, stop eating, and they stop drinking, and they start having UTIs, and they have all these other things, but everyone's like, wonder why that's happening, and they don't get to the source of the problem. Now, talking again to this, that's why I'm giving you these like Halloween candy, because I just love that Consumer Voice created these. There's a whole bunch more, and so you should take them back and give to your staff. But it's on the back of this thing is a list of the drugs to look for, and with their generics, because you're going to see them. Their generics don't jump out at you. If you saw Risperdal, that would jump out at you, but the generics for these drugs don't necessarily jump out, and that's why we devised this as one of our first things as part of this joint campaign, so that people could just carry this with them when you're in a facility and go, well, let me just run this. I don't know what that drug is. Let me just look at this. Oh, crap, that's one of the drugs I'm supposed to be watchful of. Because this woman is slumping in her wheelchair, or she just had a fall yesterday, and I think she might be on one of these drugs that that Lori's organization said is problematic. Now, why are these problematic? The FDA has put them on the market. They're approved, but they're not approved. They're explicitly disapproved for people with dementia. And that is because they have a higher rate of death when used with people with dementia. And the testing that they did for the FDA to get to this point, this is about 15 years ago, right? That they did testing on people who were in their 60s, 65. And for those people, when they were given these drugs and they had dementia, it was a 3-time higher likelihood that they would die. Imagine you're giving these drugs to an 85-year-old who also has diabetes and high blood pressure and other problems. The likelihood of having bad outcomes for them is much, much, much higher. So this black box warning is literally like it's a black box on the label of these drugs. But the pharmacist is the only one who sees that black box, right? So the nurses are giving these drugs out right in these little cups, and there's no black box around the little cups. So these nurses aren't even aware necessarily of how dangerous the drugs are that the doctor has ordered for the resident. And that's why we made this. So if you are seeing or hearing about, people being on, I went to a facility once and they kept Risperdal behind the nurse's station. So that anybody who was agitated, they were just like, take one of these. And they just gave them whether there's a doctor's order or not. So you just have to be very, very cautious about how drugs, what's the culture in the facility around drugging? Like that's a thing that is palpable in some of these facilities. If you hear that there's a bunch, and this is really a pattern that we've seen in the lawsuits that we've brought, where there would be a large number of people on psychotropic drugs. That's very weird, right? Like, because older people don't just suddenly become schizophrenic. It's just not a thing. And so why are they suddenly, so many older people getting schizophrenia drugs? That's just something that should make us go, that's suspicious. But it's a treatment modality in some facilities because culturally in that facility, they're either understaffed or they've just become so bought into the off-label use of these drugs that it's just common. It's a common thing. Or they all have the same medical director, and the medical director likes to use these drugs. So I think it's something to be, this is not a needle in the haystack kind of situation for ombudsman. I really don't believe that it is. I think there's palpable evidence when you walk in and see somebody that this is a person you need to be a little bit watchful of. If they are not able to communicate well with you, or they're slurring their words, or they're isolated in the corner and sleeping in the hallway in their chair, that's unusual behavior. That's not a natural aging process thing, So I think that this is one of these bright line things. I know ombudsmen have so many things to deal with, but to me, this is a thing that is one that you can walk in and go, oh, there's something wrong in this facility. This is not right. Now, Jonathan will go more into this, but the other thing to think about is, and Jonathan speaks much more articulately about how all behavior is communication. One of the other things to think about is if somebody who you have been working with is acting strangely, the question is why, right? It's just, if there's a change in behavior, they might be communicating illness, they might be communicating frustration, boredom, they could be communicating a whole host of things. But a drug is not the answer to those problems, right? A drug is a way to mask the problem, to take away the person's voice, which they're trying to communicate, even if they're not communicating with their voice. So I think that it's another thing as advocates is like always be thinking, did somebody test this lady? Did she when was the last time she had labs? Does she have an infection? These are reasons why people act out, or in the words of the facility, act out, but they're really communicating discomfort or communicating some other thing. Hunger. There's one of my other cases also, one that Jonathan as an expert in. We had a gentleman who, he and this other guy just didn't get along, another resident. They just really didn't like each other. So they gave, the one guy like that to him, and he gives the other guy a sock on the arm back. Both sent to the psych hospital immediately because they had an altercation. And so this was just a policy the facility had and whatever. So once he's in the hospital, that's when they stopped his dementia drugs, he had been on Aricept, which had been helping the progression of his dementia. But then they put him on like 2 different antipsychotic drugs at the hospital. So when he comes back from the hospital after 20 days, the nursing facility just keeps giving him the drugs and never questioned, like, well, wonder why he needs this now. He was only gone for 2 weeks. Like, he suddenly has schizophrenia. They just kept the drugs going. And so that all started just from this short stay psych evaluation. And he was on these drugs then they added another one because he was not reacting well to the drugs. Seems like to me in psychiatry, if you have a bad reaction to a drug, the first thing you do is add another drug. But that was how this poor man ended up on 3 different very serious drugs. And when his daughter said, "You've got to get him off of this now, like do it appropriately, but start the process," they cut him hard, like right on that day. And he started shuffling his feet so aggressively in his wheelchair that he just wore all the skin off the bottom of his feet. And then he died. He died soon after that. And that's when we filed the lawsuit. But when I took the deposition of the medical doctor who had prescribed this, and I said, like, how much time did you spend with him before you decided to like keep him on these drugs when he came back from the hospital? And he's like, "Oh, I actually never met him." I'm like, well, that maybe was your first problem, but then secondarily, like, why didn't you evaluate whether these drugs that came at the hospital with people who don't know him well, and you've been working with him for 3 years, you didn't think he needed these drugs. Why did you just suddenly just accept the medical judgment of people who don't even know this man? And he's like, well, again, they had him in the hospital. I just figured they're doctors, and the amount of deference that is given to no offense, Jonathan, but the amount of deference that is given to doctors is part of the problem here. Is that we all, our families, us as residents, us as advocates, nurses, everybody is like, oh, the doctor said it was appropriate. So then we all just like, oh, well, must be appropriate. But that's part of what I think we need to question, because the culture, this has been like the world's most successful off-label promotion scam, is that these companies have paid literally billions of dollars in penalties for having promoted these drugs into nursing facilities, and it's still reaping benefits for them. They are still having all this off-label use in nursing facilities, and it's been using older people in nursing facilities as guinea pigs, not even guinea pigs, as cash cows, because the profitability of the manufacturers continues to grow as more and more nursing facility doctors continue to order these drugs for people. And it's become so common. And that's part of the reason why Consumer Voice and AARP Foundation did this campaign, because we're like, we have to change the culture. It can't be just so culturally acceptable to give people poison. It's just, for people with dementia, it's like giving them poison. And I get yelled at by people at AARP all the time, because when CMS did they did a campaign to decrease the utilization of these drugs. It went from 15% utilization down to 12. And they're like, victory. We're like, well, there's still 12% of the people being poisoned. Like, that's not victory. That's not how we measure victory. So I think that but this is why it's such a pervasive cultural problem in facilities, that we just tolerate it, Oh, sorry. This thing does not want to stay up. But I think that from the perspective of Ombudsman, we want to arm you with as much information and evidence as you can get for volunteers, for families, for residents themselves. And there are lawsuits to be brought still. So if you encounter people who you feel like are in such a bad situation that, or some, God forbid, a family member dies, that you can reach out and we can help to find attorneys willing to bring these cases, because they are willing to bring them. There's the case that I was just describing that we had with Jonathan. We brought that as a street battery case, like it's unlawful touching. Somebody's touching you and you don't want to be touched, that's an unlawful touching. That's a battery or an assault. And so we brought it as a street, because to me it's so pronounced, it's so it's so much more dramatic to say that it's an unlawful touching. You have put something into this person's body that is not authorized, it's not appropriate, and they didn't want it. And you have done it with no authority. And so there are a lot of clever statutes around the country that have yet to be tested for this. But I would love to have an army of attorneys bringing these cases to try to make the strong point that the culture has to be changed. The other thing that I would say is the other side of, so these cases where people paid all these penalties, they were paying it in kickbacks. So the manufacturers were paying kickbacks to nursing home chains and to nursing home pharmacies to get these drugs into the facilities, because it's a perfect crime. Like, there's like no paper trail. You just pay, and the people suddenly are like prescribing these drugs. This happened with Depakote, it happened with Risperidol, it happened with a variety of drugs. And the companies, Eli Lilly paid $0.4 billion in penalties for paying kickbacks to get these drugs into the facility. And they still, it's not enough. Like, they don't really, there's no penalty there for them, because they still made so much more money by getting the drugs into the facilities that it's not really much of a penalty for them at all. They also took a criminal plea, and then they still were able to like continue to promote these drugs. But the other side of this is the pharmacies. So nursing facilities all have a pharmacy that they work with to fill the scripts, right? So the doctor writes the script, the pharmacy has to go look at the script and go, now, after the ACA was passed, the pharmacy has to go, is there a diagnosis that supports this medication? And so the pharmacist should be the gatekeeper to the drugs. They're supposed to be safeguarding that people who don't have a proper diagnosis, a proper mental health diagnosis, get these drugs, but they're not. And I shouldn't say all of them are not, some of them are, and some of them will then convene a case meeting and ask the facility and the doctor and the nurse and the family, why are we doing this again? What's the alternative? Is there an alternative to this drug? And are you aware this drug doesn't treat dementia? It really is, it's just a way to mask the communication. And so that's something else to be watchful of. I know that's a lot to have on your plate, to be watchful of how the pharmacist runs with the facility, but it's a core part of their function. They're meant to be a security guard of sorts, to make sure that people for whom these drugs are inappropriate don't get the drugs. But so that's the other side of the kickback, though. There's one company has had 3 different huge False Claims Act cases against it for accepting kickbacks to get the drugs into the facility. But that's how it works, right? It's a perfect scheme to get the drugs into the facility. But they still continue to operate with many of the larger chains, Life Care, Genesis. They continue to be the corporate pharmacy that works with these larger chains. So I think that the major message is to, and not to be totally over dramatic, but this isn't contained only in nursing facilities. This is a big problem in assisted living. It's even a big problem in home care, because some doctors will say, well, in order to keep you at home, we're really going to have to give you some meds because the family members are having a hard time. That at least involves informed consent, because the family is at least in the discussion, right? But when it's happening in isolation of the family or of a legal decision maker, that's especially problematic. But in assisted living, we've now seen this much more commonly than we were. It was really contained in the nursing facilities, but now it's showing up a lot more with assisted living as well. So I think that there are, as Lori has pointed you to, there are an infinite number of resources, but I honestly believe that information is the best way to get the word out on this, because people just need to be able to recognize it, and they need your ombudsman, your volunteers, the surveyors, the nurses, the CNAs, everybody needs to be able to recognize this is a problem, and like the CNAs need to feel like they could say no. They could say, why are we doing this again? Shouldn't we have a meeting to discuss if there's an alternative to giving, Kelly this drug that could be very dangerous for her? And so you know, a part of what Lori and Jonathan and I have tried to do for the last many years with this is make sure that people know they're not alone and that nobody has to fight these battles without information. There's so much good information out there now, but it also might need you know, more training for the line staff. And so both Lori and I think Jonathan too, have gone around to various teams of ombudsmen and trained the actual teams themselves about how to recognize this, because it's hard. It's like it's not a great train the trainer model. So we train you, you go back and train everybody. But if there are ways that we could do virtual trainings. I just did a virtual training for all the Illinois ombudsmen on this subject. So I think it's something to think about, that there's more information that we need to get into the hands of the people who are actually walking into the nursing facilities. And that's the best way to empower them to see, to recognize what it is that's in front of them. It's hard to see it, and especially when you're seeing so much of it, and it's hard to realize it's not acceptable because it's so common, because the culture is so pervasive. All right, I'm going to turn it over to Jonathan now.
All right, thanks. Well, look, I just want to clarify one or two things and summarize some of what you heard before I do my thing here. Okay, first off, I am a physician. Okay. Oh, because you're recording. Okay, sorry. Well, I'll just wander. Can I take it off and wander? Okay, I'd have a hard time sitting still. So, my name's Jonathan. Only my mother calls me Dr. Evans. That's because I make her. Okay. But unless you call me an asshole, and then it's Dr. Asshole to you. Okay? All right. And my specialty is geriatric medicine, which is, you know, basically focused on the care of older people and particularly issues related to medications. And people in my field, we stop more medicines than we start. And here's why. Someone comes to me, they're taking 19 medicines, they've had a lot of health care, and they feel bad, okay? The likelihood that the magic number 20 medicine that no one thought of is out there, that's gonna erase everything else, is very low. But the likelihood that, I mean, statistically, if you take more than about, well, if you take 9 medicines, any 9 medicines, the likelihood that there's going to be a significant interaction between those medicines is 100%. Okay, so you know, part of the culture that I was brought up in is, at least in geriatrics. Well, I was trained in internal medicine, and then I was trained in geriatric medicine to basically forget everything I was taught in internal medicine. Okay, to some extent. So having said that, I want to say a couple things about medicines, and then we're going to not talk about medicines. All right, the use of these medicines goes back at least 80 years. The first such medicine was a drug called Thorazine. It came out around 1950, and so that's not quite 80 years. But even prior to that, there were, you know, other medicines. And I guess it's important to understand that, you know, I mean, there ought to be a slogan for the AMA or something that says drugs. It's what we do. Okay, you know. So it's part of the culture. And moreover, in healthcare settings, we medicalize all aspects of life, okay? Just about anything happens in a hospital or a nursing home, anything that goes in or out of a person's body requires an order from a doctor, okay? So that means I have to write orders for people to have a beer and stuff like that, which, you know, I was not specifically trained for, okay? But, you know, as a result of that, the mindset is that, you know, if somebody can't sleep, you give them a medicine and so on and so forth. The other key thing to keep in mind is that medical environments and nursing homes, for starting at least in 1950 and even prior to that, you know, there was a concerted effort to build nursing homes, and there was federal legislation passed in around 1950 that basically supported nursing homes even before Medicaid, but it required that nursing homes basically look like hospitals. Okay, and so the key thing to remember is, these environments, these healthcare environments, they're inflexible and restrictive, and you're expected to comprehend the environment and conform to the environment, okay? And if you've ever been in the hospital, you've experienced that, okay? So, but basically, the last thing I want to say about medicines is that these medicines actually don't work. They don't work to make people behave better. There's no such medicine, all right? There are medicines that sedate people, you know, but if anybody's using a medicine to make somebody else behave, that is by definition a chemical restraint in my book, okay? Just to keep it simple. Now, Historically, there's been a big focus on one class of drugs called antipsychotic drugs, and most of the medicines on that list are antipsychotic drugs. But they're not the only medicines that are used for this purpose, and some of the medicines on that list are not antipsychotic drugs. You don't necessarily need to know what category they're in. It's just that when you look at the nursing home compare, they say antipsychotic drugs. They also say sedatives and stuff. I don't want you to be fooled into thinking that if it's not an antipsychotic drug, it's not a chemical restraint. Okay, and all of those medicines on the list have been shown to increase death, and all of them have been shown to be ineffective at making people behave. So basically, the upshot is all these medicines that are being prescribed for this purpose, people are taught to do that. You know, that's the only thing they're taught about this. And so they're doing what they believe is the right thing because someone told them to do that. It doesn't work, but they either don't know that or basically, there are lots of things in healthcare that have been shown to be ineffective, but doctors and others do them anyway because everything that you believe in your life is filtered through your own lens, okay? The lens of your own experience. And if someone tells you, I don't know, the sky is green, and you look up and it's actually purple to you, you're not going to believe that the sky is green, okay? And if somebody says there's a study that shows that the sky is actually green, you're not going to believe that, unless you see it for yourself. And so, there's all this scientific evidence out there in all aspects of medicine, but people are taught things that for which the evidence is the opposite, but it still happens anyway. It's not limited to these medicines, but these are some of the cultural issues that Kelly talked about, okay? So when you think about it, these drugs, they're expensive. It's money that could go to staffing and other things. They don't work, okay? And worse than that, and they're harmful. They're harmful either because in some instances they kill people or they cause them to be, these drugs slow down your brain, okay? And they're given to people who already have brain impairment. So what possible benefit is that likely to have, all right? So what I'm getting at is even though these are prescribed by doctors and so forth, I don't think of this as a medical issue, okay? You can think of it as a stupidity issue, okay? But really, I think of it first and foremost, and I think you got the sense of this from Lori and Kelly, is that this is really a moral issue, okay? And let me illustrate the point, okay? Now, I do a lot of training and teaching with doctors and nurses, and they will swear on a stack of Bibles that they're prescribing well, this is the right thing to do, and so forth, and we won't agree on anything until I give them a case, okay? And here's the case. I say, did you hear about this new medicine that just came out? In fact, it's awesome. It costs almost nothing, okay? It's incredibly safe, it's been well studied, and it's been proven to be effective. And have you heard about this drug? It's been proven to be effective such that if you take this medicine, it will cause you to behave exactly the way the person that gave it to you wants you to behave. Okay? And I say, well, I'll ask you, how many of you would be willing to take that medicine under any circumstance, and who would you let give it to you? Because that's really what we're talking about here, okay? So it's not an issue, it's not a matter of price, it's not a matter of effectiveness. Okay, it's safe, it's effective, it's, and so forth. It's, when I say to the same person that says, well, I'm being mean by denying this patient some medicine for their, quote, comfort, because they're agitated, and then I ask them, well, would you take a medicine, if your husband or somebody else said you should, and they would say not only no, but hell no, and I said, well, why not? It's kind of hypocritical, and they said, well, because freedom, okay, or something like that, because it's a moral issue. Okay? Now, so having said all that, and let's get down to the practical, okay? Here's what I'm going to do. By the way, 85% of all antipsychotic drugs prescribed under the Medicare program are prescribed to people with dementia, okay? So they're prescribed, and it used to be about $4 billion a year. Some of these drugs are generic, maybe it's just $1 billion, but we're talking about a lot of money wasted on something that doesn't work and is harmful. So here's what I'm going to do. For the amount of time we have remaining, I am going to start now. I usually start. I have to talk for a while before I start thinking. So hopefully we'll get to that point here. So I'm going to start by giving you a few minutes, nothing too taxing, a few minutes of formal training on dementia and behavior. Okay, and after that few minutes, you will have received more medical training on this subject than 99.999% of all doctors and nurses that work in this country, okay? And therefore, after you leave here, you will be the expert in all the communities that you go to, with the possible exception of some of the CNAs that you work with, okay? Because what's happened here is we have medicalized things. We have tried to convince doctors and nurses that these are medical issues, and when people, well, it's like this. There's those of us that are seekers of truth, and then there's other people you run into who have already found the truth, and so you can't talk to them, okay? Because they know everything, okay? And so once people believe that they're right, there's no helping them, all right? So let's just talk about it. Here's what I want to cover real quick. And here's my goal, okay? I want to talk about what dementia is. I want to make sure each of you really has a firm grasp of what this thing is and why it results in people behaving a certain way, okay? I'm going to convince you that these behaviors are actually normal, okay? And we'll talk about which ones they are. And then we'll talk about, with a few specific behaviors, why do they do that and what can we do instead? And when you leave here today, you can go back to your communities and you can be that critical resource to help people deal with these difficult things, okay? And just remember that, think about anything else you learn in your life, at the beginning, everything's difficult. But once you learn it, then it becomes easy, okay? So your challenge is to make it easy and convenient for people to do the right thing. All right, so what is dementia? I'm not going to quiz anybody. I just like to ask questions, okay? Feel free to answer if you want, but I'm going to suggest that you think about dementia not as a disease per se, but really as a disability, okay? And basically as a condition in life that that causes people to sort of think differently and respond differently to different situations. So the definition is very simple. It's a loss of brain function or brain power bad enough to interfere with daily activities. So it's not about plaques and tangles or anything like that. It's not a MRI or CT diagnosis. It's a functional diagnosis, okay? And it's permanent. The main features that you will, and there's Alzheimer's and there's all these different flavors like Baskin Robbins. Ignore all that stuff, okay? It doesn't matter, and most of that doesn't hold up anyway. So, what sort of impairments do people have who are living with dementia? Well, the most common things are loss of short-term memory, an inability to plan, okay, and sort of the part of the brain that controls other parts of the brain doesn't work. So your short-term memory is impaired, you can't make and carry out plans, and you may not be aware of your surroundings. We'll call that disorientation, okay? People may not know what the year is, they may not know what this building is, they might, and so forth. In fact, the place where you go to bed at night, where you live, what do you call that place? That building? That's your home, okay? Obviously, Consumer Voice has spent, I believe, 46 years trying to help people understand that where people live is their home, okay? But if you, but the thing is, in your home, what rooms are you allowed to go into? All of them, okay? So if you think you're in your home, you are gonna go wherever you want, because it's your home, okay? Pretty normal, let's just say. And by the way, how many of you have children, grandchildren, or have ever been a babysitter? Or anybody that hasn't done any of those things? Okay. All right. Well, it's not too late. Okay. All right. Well, that's good. But for the rest of you, you already are experts on all these behaviors because you've already successfully dealt with them. Because all these behaviors that we're going to talk about that are so difficult, they're actually normal behaviors for young children. Okay. For 30 years, my oldest child is about to be 30. For 30 years. I've been talking about this for longer than that, but after I started having kids, I made them my props. And so for 30 years, I would talk about these cases, and I'd say, I have this difficult case, this guy or this young woman, not young, but this person who's been the resident of this home for the last 2 years, who's kicking and biting and stealing other people's property and, quote, resisting care and is incontinent and so forth. And they'd say, Haldol or Risperidol or whatever. And I'd say, well, wouldn't you like to see the patient? I've arranged for them to be brought here for you to examine them. And then I'd trot out one of my 3 kids, okay? Because they're all those same behaviors, okay? And basically, these are normal behaviors for the degree of brain function. Number one, they're normal. Number two, they're like a reflex. They don't require conscious thought.
And the idea that people are planning this and doing it on purpose is false, okay? And so, one of your jobs is to dispel people of that notion, that they can help it. Now, what are they responding to or reacting to? The environment. And what in the environment? Often the person that's in their face, okay? Often the very person who's supposed to be taking care of them. So we'll get through that, we'll go through that in some specific examples, okay? Now let's just, I don't mean to pick on anybody or make anybody uncomfortable, but let's say you were in your hotel room last night and suddenly the lights come on and 3 strange people you don't recognize are pulling at your clothes and saying, oh, we're trying to help you. What are you gonna do?
Fight back.
Fight back? Who said that? I don't mean to put you on the spot, but just between us, when's the last time you actually kicked anybody's ass? Is that your habit? Is that your profession or whatever?
Absolutely.
Okay, all right. I won't argue with you, but I have a sneaky suspicion that if that is your job, it's your side hustle. Okay, all right. Okay, I'm going to bet that most of you that said you would.
I am an ombudsman.
All right. Well, that is your job then. Okay, but there again, you're counterpunching. You're responding to a threat. Okay, and you don't even have to be fully awake. Okay, all right. And so the point I'm trying to make is these behaviors, these difficult behaviors. There are people. The quote most difficult ones are people who perceive a threat, who are responding exactly the way you would if you were similarly threatened, okay? So let's go over some cases, all right? And by the way, there's other things, before I get to that, there's other things that happen that are a consequence of the physical environment, okay? So let me give you an example, a couple of examples of that first, and how, people can't comprehend the environment and they get into trouble for it. And by the way, in terms of the abilities that people lose with dementia, basically, it's like the things that you develop the higher order things that you develop latest in your life, like your expansive vocabulary, for example, that starts to shrink. So the things you learned later in life, that goes away first, and then the last things to go are things like being able to walk and stuff like that, all right? So just so you have an idea. All right, so here's some environmental things, right? Somebody, this happened in a locked memory care unit. By the way, memory care units, unfortunately, ironically, tend to be some of the worst offenders in terms of this kind of stuff, okay? So basically, this guy who's able to walk, he's in this locked unit, he goes out the door. He goes out the emergency exit. And they have a fit, and then somebody else sees him doing it again. They actually tackle him. Why did he go out the door? Exactly. He was told to go out the door. Who told him to go out the door? The building, exactly. Big red sign says exit, okay? All right? Okay? Or for that matter, typically it's evening, someone's already had their dinner or whatever, and it's getting dark. Now it is dark, that time, and they see the front door, and they say, well, I got to go home and take care of my family, and they walk out the front door. Okay, again, they're reacting to, it's not like they made plans all day. Okay, 6 o'clock, I'm out of here, okay? They just, in a moment, they saw a stimulus, they responded to it. It's like a reflex, just like you beating the crap out of the 3 people that tried to attack you last night, okay? Sorry for my limited vocabulary. Mark Twain said that at times, profanity provides a relief denied even to prayer. So I'm feeling particularly spiritual at the moment. Okay, so, all right. So here's a couple of other things. This is going to be a no-brainer for you, but I've seen this half a dozen times, maybe a dozen times in my career. But the first time I saw it, it was pretty baffling. This sweet woman who didn't see very well, didn't hear very well. She's 90. She's got some mild dementia, but she's very independent. She kept pulling the fire alarm, and the fire department became very upset, and they were threatening to fine the building. And so basically, they basically gave her 30-day notice, okay? And I won't give you all the details, but we had this big powwow, and at the end of that, they said, well, we can't have her here. And the director of nursing said, oh, it's such a shame, she's such a sweet woman, it's too bad we have to make her leave. And it was the nursing assistant, the expert, who said, the DON said, I just can't figure out why she keeps pulling the fire alarm. And what do you think the nursing assistant said? She said, it does say pull on it, okay? And in fact, it says in big letters pull. In small letters, it says in case of emergency, okay? So once they realized that she was responding to the stimulus, then they knew some things they could do. You'll see oftentimes a fire alarm will have a cover on it that might even, you have to break or something like that. In this case, it was Minnesota. They, on an 8.5 piece of white paper, they just put a sign up above the fire alarm that said, not you, Ethel, in big letters, okay? All right? So the environment was telling her to not pull, okay? All right? And that was very effective. All right, so this is a little trickier one. A guy is urinating in the plants. They got potted plants, or in a trash can or something like that. Okay. Okay, well, first of all, and I'm sorry, I'm breaking our code here. I apologize. There's a guy code. You know, certain things you're not allowed to tell anybody, but the first rule of the guy code is don't tell anybody there's guy code. Right? But the thing is, we only have one X chromosome. Okay, so we're talking about a genetic condition, all right? A disability, if you will, okay? And basically, the bottom, and so guys pee a lot, older guys pee a lot more, and if anybody actually manages to go in a round receptacle, they get a B+ in my book, okay, all right, okay? You know, because they recognized they had to go, they knew that there was a place to go, but they had sort of forgotten part of the rule, okay? And this is, so how do you manage that? Well, when does he go? When's he likely to go? You anticipate that need, and you take him to the right place, okay? Because he thinks he's in the right place. So you can't say, no, you can't do that. You can't say, I mean, it's pointless to medicate the guy, you know. This is normal biology, and for that matter, these medicines make it harder for people to urinate, so you're gonna cause even more problems. All right, so those are just some of the environmental things. The resident-on-resident stuff is often because people have nothing to do. They perceive a threat. Again, if somebody was going into your room, and you know, you would be offended or threatened or whatever. So here's a situation I ran into within the last year. I get this frantic call. I'd actually been there that day. I saw this woman. She's fine. She's 85. She's got mild dementia. She's healthy as a horse, and she's able to walk and go to the dining room and back. Well, a couple hours after I left there, I got this call. Hey. A frantic, distressed nurse, okay? And by the way, the use of these medicines is a reflection of caregiver stress and frustration, okay? That's really what's going on here, okay? It's not related to the severity of symptoms or illness. About 12% of all nursing homes nationwide don't prescribe any antipsychotics for dementia, so it's not like this is mysterious. It's part of the facility culture, okay? So, frantic call. It's 8 o'clock or 7 o'clock at night, it's bedtime there, okay? She's naked, and she's in some guy's room, okay? By herself, there's no guy in there, okay? But even so, that wouldn't matter necessarily. And it's right across the hall from her room. What are you gonna do? You know, okay? And I was like, what do you want me to do? Oh, what medicine and so forth. And I had to bite my tongue from saying, well, I'm not gonna prescribe for you, you're not my patient, you know, but the patient was fine. They weren't upset. They were just lying in bed. So I was like, gee, let's see. And so I was trying to reframe this. So when you go home at night, before you get in bed, what do? Well, I change my clothes, or whatever. And then you get under the covers, right? So what did she do that was not normal here, okay? Well, she was in the wrong room, okay? So, so I asked the nurse, you ever do that? No, never. You've never gone in the wrong room? You know, oh yeah, all the time. When's the last time you did that? Today. Okay. Why did you go in the wrong room? Because they all look alike. Okay. You know, and so this is an easy problem to solve. Either you make it easy for her to find her room, put big letters there or something, or you take her to her room after dinner. Okay. Problem solved. Okay. Why did, you know, but there's not a doctor or nurse out there that hasn't gone into the wrong room, talked to the wrong patient, and stuff like that. And unfortunately, in healthcare settings, the med error rate, the acceptable med error rate is up to 5%. So it's not at all uncommon for people to get the wrong medicine sometimes. And if you ask them, well, why'd you give them the wrong medicine? You get a similar answer. Well, they all look alike. Okay, all right. So how do we deal with that? We give them pictures and other things and so forth. So again, a lot of this is people expect folks to conform to the environment that they can't comprehend. Okay, And we have to change the environment in subtle ways sometimes if we want to give people clues to help them do what they want to do, or we have to anticipate their need and help them get where they're going. Now, I have a colleague whose father was a fairly prominent physician in San Antonio. He developed dementia in his early 90s. He ended up in a very expensive assisted living place. And what happened is every single night for several weeks, 2 or 3 in the morning, he'd get up, he'd say, I want breakfast. They'd say, it's nighttime, go back to bed, okay? And every single night at 2 or 3 in the morning, they would call his 2 daughters, and then they wouldn't sleep because they were saying, if he doesn't stop it, he can't live here and so forth. And finally, they contacted me and said, what should we do? And I said, well, listen to the story. I just have one question. When does he go to bed? 7 o'clock. That's when they all go to bed. All right, so he goes to bed at 7. He sleeps 7 hours, or sometimes more, and then he wakes up. Well, let me ask you, this is a remedial question on my part. When you wake up, what do? You get out of bed. When you're done sleeping, you get out of bed and you see. And what would you typically eat? Breakfast. Okay. Does it really matter what time it is? Just when you wake up, that's breakfast time. Okay. So this is an example of facility. First of all, this is a completely manufactured problem. This facility made him go to bed at 7. Made everybody go to bed at 7 for staffing reasons and so forth. Then they couldn't comprehend why he would be getting up 7 or 8 hours later, and then they basically were totally unprepared to anticipate or meet his needs, okay? So that's the solution to that is not that hard. Either you keep him awake longer, or you give him breakfast, okay? All right? Is that a disease that we're talking about now? I mean, is this a medical issue?
There's always a possibility too that that's what they did for a living. They were
Absolutely.
truck driver, taxi service.
Yeah, I'm glad you mentioned that. Not everybody works the day shift, okay? Many people, you're expected to conform to this environment and the routines of the environment. But if your biological clock is different, then you're not going to do that. I was involved in a case where basically someone died as a result of being chemically restrained, and this guy's story was he was a car salesman and he was a volunteer firefighter, okay? And what was his crime for which he basically ultimately was sentenced to death? He'd see something shiny and he'd try to polish it because that was his job, okay? And he was often up at night, okay? And he was not somebody, in his jobs you just didn't sit around, okay? But so, and that's the other key thing about that, to your point, is knowing a person's story, helps to interpret some of these behaviors. I've had a few situations like a guy, every evening around 5 o'clock, if they'd say it's dinner time, he'd start howling. He'd go something like, whoop, whoop, he'd make this woo, woo sound or whatever, And he was fine otherwise, but it was only in the evening, and usually it was when they said it was dinner time, okay? And this went on for a few days until his daughter came in. I was like, hey, things are going well. Hey, he does this thing, what's that all about? She said, oh, he's calling in the dogs. Okay, other people are calling in the hogs and stuff like that. So, that was his routine. He lived out in the country. He had dogs that were outside. When it was dinner time, he'd bring in the dogs to be fed and keep them in the house at night. So once we knew that, it was like, great. So here's what we did. The next night, when he said it's dinner time, he started doing that and said, hey, the dogs are already inside, okay? So, okay, so he was doing his job, basically, okay? So, all right, so here's a couple, so these difficult behaviors, what are they? Well, let's say, I hate some of these terms, but I'll say the worst ones. Aggression, being a danger to oneself or others. Resisting care, okay? Agitation, okay? Let's talk about, and wandering, okay? Let's just talk about those in less than 5, but in a couple minutes each. All right. 10 minutes left, so I won't take all 10 minutes. All right, being a danger to yourself and others and being aggressive, that's not possible if you have dementia, because those require planning, okay? So it's not being aggressive, it's being defensive. Agitation, nobody outside of healthcare ever uses that word, okay? Here's the thing, let's say your mom's in the hospital and you get a call and they say, hey, your mom's agitated. Oh, that sounds terrible. Well, what are we going to do? Oh, we'll give her medicine, she'll be fine, okay? But agitation is not a disease. It's not a medical thing. It's somebody notices that somebody is visibly upset, okay? So what if instead you got a call and they said, hey, your mom here in the hospital, she's upset. Oh, that's terrible. What's she upset about? Oh, it doesn't matter. We just gave her a medicine, okay? That would be completely intolerable, okay? So the point is that, agitation is not a disease. It's a sign or symptom of something else. The question is, what is that something else? And figuring that out. All right, and again, it's reactive, okay? And for that matter, people often respond to a lot of nonverbal stuff, even more so than verbal communication. And if your boss sent you an email and said, bad news, I'll send you another email later, you would probably not be satisfied with that. You would probably, at a minimum, you'd want to call them and at least, not just to discuss things, but also to hear the tone of voice and other stuff, And if you're, if you're with somebody you love, your brother or somebody, and you're having a conversation and they're saying, I'm not mad at you, I'm not, well, they're telling you get conflicting messages, you're always going to go with the nonverbal one, okay? So if I'm standing over somebody, that's a somewhat threatening, I don't mean to put you on the spot, threatening thing. Let's say I'm going to help you get your teeth brushed, okay? And I come at you with this, I'm standing over there, I'm trying to shove this thing in your face. That's also threatening. Or here, I'm going to comb your hair, okay? So, how do you, so even these little tasks can be misperceived as threatening. So what do we do instead? Well, we put the hairbrush in their hand. And then I say, hey, let me help you comb your hair. I show you what to do. Or here's a toothbrush. Let me help you brush your teeth, okay? So, and not standing over people, okay? When somebody's upset, I get as low as I possibly can. First of all, I want them to see me and hear me, okay? But even just standing over somebody is potentially threatening. If nothing else, they seem like they're in a big hurry or something, and that can be anxiety provoking. I like to sit. I'm kind of, anyway, all right. So resisting care is basically so here's a case. 80-year-old former nun, well, she's a nun, okay? And she is in a nursing home, she's got dementia, but every time they she's incontinent, every time they try to change her brief or take her to the shower, she fights like mad. Why would she do that?
Because she's a nun?
Yeah, right. I'm trying to make this as obvious as possible, but if this was a group of nurses and doctors, I'd be like, okay, think about it. You need some more clues? Okay, she's an N-U-N nun, not N-O-N-E. Okay, stuff like that, what I mean? All right. Because they're trained to think differently, okay? So obviously, that's not nothing in her life prepared her to be undressed. And for that matter, you see this frequently. Let's say, I just was discussing a case the other day with a group. A guy who'd been married for 70 years to the same woman who just recently died, okay? He's in a nursing home, and young women are trying to undress him and stuff. And in some instances, men respond, men would say, they think that somebody's their partner or whatever, or that they're interested in them because that's their only frame of reference. The only time any woman's ever undressed me has been, whatever, okay? I'm not speaking from experience, okay, necessarily, that was rhetorical or hypothetical. Okay, but alternatively, this guy who had been married for 70 years, he was really he was pushing them away. He's like, go wash yourself, and stuff like that. And he's basically saying, that's wrong. He was morally offended, okay? So you have a misperception here, okay? And things are misperceived. Now, how do you deal with that? You explain things. You break things down into single steps. Obviously, in that setting, he responded better to a male caregiver, okay? That's not always possible, all right? So you get the idea about resisting care and agitation. Let's talk about wandering. Anybody ever do that? Yeah. I'm not talking about your marriage or anything like that. I'm just talking about walking around in an apparently aimless manner, okay? Or going somewhere where other people don't want you to, right? So it's normal. It's normal for people to move around. Maybe the lady that wandered into the wrong room. She thought it was her room, okay? So, I guess I'm being kind of repetitive here. So you understand that the condition of dementia causes people to be unclear about their surroundings. They can't always remember the social rules. They can't conform to the environment. So we have to modify the environment. We have to modify our approach individually. And in some instances, just some minor physical modifications can make a difference. The other thing is, last thing I'll say is, I mentioned these are normal behaviors in young kids. Well, what if we had a daycare center with this many people in it, and the only time we ever actually interacted with anybody was to perform a task, which is what medical care delivery has become? What would happen? Chaos, right. Do you think that there would be resident-on-resident incidents? Do you think there would be wandering? You know, do you think there would, all these things, a lot of this is simply that people are not engaged. They're bored, and we wouldn't accept it in any other circumstance. So we cannot accept it in this circumstance either. Anyway, that's what I got to say. I'm happy to answer your questions, but thank you for indulging. That was normally like a 9-hour thing, but Kelly has gotten me down to a very small thing. It would have been shorter, but I didn't have
Years of work to
Yes.
abbreviate it.
So I think we have maybe 2 minutes or time for one question? One or two questions?
I wanted to throw out, I'm from North Carolina, I'm an ombudsman. I cover mainly what we call North Carolina adult care, so assisted living. Our system has somehow made itself that all of our dementia care units are in assisted living. So we have very few in skilled nursing facilities anymore. Everything we've talked about is so bad in assisted living.
Yes.
I don't know how to explain to you. It's like the wild, wild west. That I joke, this is my coworker, she covers for nursing homes, and I'm like, oh look, you have rules that you have to follow. In assisted living, it's like, we can chemically restrain anyone we want to. And I think Dr. Evans, you'll appreciate that when I, get a discharge case for behaviors, right? Oh, there's behaviors. I'll look at the form and their notes and I'm like, okay, agitated. What actually happened? And my favorite thing I tell staff is, I'm now agitated, reading your notes, that someone's agitated, but it still doesn't tell us anything.
Yes.
And this is
Yeah.
becoming a really pervasive
Yes.
So for purposes of, because we're recording part of the session, so for purposes of that, the questions related, it's okay, because we don't have mics all in the back, is that this is happening in assisted living and memory care units and where we don't have the nursing home regulations. So the rules are a little bit different with respect to, rights issues and things like that. But we're having the same problems. So
Yes, and I think there's also going to be a session on this specifically with regard to assisted living during the virtual meeting in a few weeks. But so yeah, you really hit the nail on the head. This, first of all, that when other people are doing something that makes you feel a certain way, that's called mirroring. If you're if you have kids and young kids and you're on the phone or you're upset or whatever, that's when they start acting up, right? Because they can sense that something's not right, okay? Or if you have a dog or whatever, okay, same thing. There's more memory. This is a big growth area in assisted living, there's not typically a lot of training. In fact, assisted living, they try to really funnel people into these memory care centers if they have them, because unfortunately, even if you had really qualified staff that understood this to try to help people in the regular assisted living, they often have the problem of other residents who just find it intolerable. Would you want someone wandering into your apartment? So there's a tendency to sort of segregate people, and that's where things stop. But everything we just talked about works there too. Okay. Now, having said that, I have about 100 patients. 95 are in nursing homes. I have a couple home care patients, and I have 3 in assisted living. Okay. Why only 3? Because without fail, they fire me. They tell the family, your doctor doesn't believe in good medicine, and therefore you have to change doctors or you can't live here anymore. Okay. So. And I tell them that ahead. I tell them, if somebody wants me to take an assisted living patient, I tell them that ahead. Oh, no, don't you worry about that. And it never fails.
Well, one thing I wanted to say is we have a case against Brookdale Assisted Living in North Carolina. So if you have specific information, let us know, because I would love to talk to you about Brookdale, North Carolina. Oh, and we also have one against Brookdale in Florida, if there's any Florida people. But we definitely, North Carolina, we're looking for more information about people in Brookdale.
What city?
It's every Brookdale facility in North Carolina is a defendant. We don't have South Carolina.
So we are at the end of our time, so And we only have 15 minutes break before the luncheon starts. If you do have another question, maybe you could come up and ask Kelly or Jonathan themselves. I'm sure they would be happy to answer them. Thanks so much for being part of this session today. Really appreciate it. So much of it is like problem solving, right? So much of it is problem solving. So I think it does get, there's more of the drug cards here. They've been down on the exhibit booth, so take them back with you. Take as many as you want, and we can send you more if you're interested in having more.
By the way, thank you for being a good sport.